So starting out with the first, that is the typhoid. So the typhoid, it is caused because of salmonella, that is gram negative. It is belongs to the Enterobacteriaceae family. There are two types: typhoid causing salmonella and non-typhoid salmonella. It consists of the Salmonella typhimurium, Salmonella gastroenteritis, and Salmonella cholerae. Then typhoid salmonella. And so typhoid salmonella, there is Salmonella typhi, Salmonella paratyphi, which has further subtypes A, B, and C. Now, very important out of which is leads to mononuclear or macrophage infiltration. Antigenic classification was based on O antigen and H antigen. O antigen is the somatic antigen, while H antigen is the flagellar antigen, which is according to Kaufman and White classification. Molecular classification is a newer classification. Then the VI antigen. VI antigen is very important. It is a capsular antigen which is covering the O antigen. It is important for the virulence, but however it is poorly immunogenic in nature, and so it is not used in Vidal test. Pathogenesis, the infective dose over here requires to be large, that is 10 to the power 3 to 10 to the power 6 bacilli, so a high inoculum is required. Then the risk factors are the decrease in stomach acidity, that is in case of H. pylori infection or antacids. There is a higher risk, decrease in intestinal integrity in case of IBD or surgery. It attacks the M cells and it incorporates within the macrophagic cells. Type 3 secretion system is activated, it enters the macrophages, survives, leads to primary bacteremia, spreads to the liver and spleen, and will lead to further secondary bacteremia. Then the clinical features, it leads to staphyloidal pattern of fever, rose spots on the chest and trunk, maculopapular rashes, hepatosplenomegaly, relative bradycardia, which is Paget sign, and GI bleeding and intestinal perforation. Apart from that, it leads to longitudinal ulcers and pea soup diarrhea. It is more common in urban populations compared to rural population. Temporary carriers are for 3 months and chronic carriers are for 1 year. Lab diagnosis is by the different specimens at first, second, third, and fourth week. It is given by a mnemonic BASU, that is blood, then agglutination, stool, and urine. And the culture, it is non-fastidious in nature, so it is non-hemolytic colonies on the blood agar. Then McConkey's agar can be used. For enrichment agar, it is a selenite F or tetrathionate agar, and then Hectoin enteric agar or Wilson Blair medium, which gives jet black colonies. Apart from that, the selective agars are xylose agar or deoxycholate agar. Then it is indole test negative and methyl rate positivity is seen. Then Vidal test. Vidal test is the most important. Vidal test is a non-specific test for typhoid. It is done usually around 2 to 3 weeks. It's a tube agglutination test. It is based on H antigen, which is more antigenic or more immunogenic in nature. So if TOTH antibodies are found in, that is Salmonella typhi. If TOH are found in Salmonella paratyphi A, TOBH are found in Salmonella paratyphi B. Antibody titer against the O antigen, if it is 1:60, and antibody titer against the H antigen is 1:80. So in a period of 2 weeks, if the antibody titers it grows by more than or equal to 4-fold, then that is considered to be a positive Vidal test. Biologically false positive results are seen in case of infective mononucleosis malaria SLE. First antibody to appear is going to be the O antigen. Last antibody to disappear is against H antigen. If TO positivity is seen, then that's early infection. TH positivity, that is late infection, and vaccine, in that all positive except TO are seen. In talking about the management, so there is a TAB vaccine, which is a intramuscular vaccine where 2 doses are given 4 to 6 weeks apart. Then virulence capsular polysaccharide CPS vaccine is given where strain TY2 is used for more than 2 years of age only. It is given. Then type oral vaccines are very commonly used. Oral live attenuated vaccine, it is TY21A. It lacks UDP, phylactis 4 epivirus. Revaccination should be done every 5 years. Drug of choice is ceftriaxone. Ciprofloxacin is given as empirical prophylactic antibiotics. Very important, the typhoid vaccine is not there in universal immunization program. Next we'll talk about the cholera. So cholera is caused because of a comma-shaped monotrichous flagella containing bacilli, that is called as Vibrio cholera. It is comma-shaped and it has got darting motility and shooting star motility. The Venkatraman classification is divided Vibrio as Vibrio cholera and other Vibrio. So in the Vibrio cholera also, it is divided by the strains into O157 and the others. O1 is further divided as classical and Entor variant. So classical and Entor variant further are divided into Inaba, Ogawa, and Hikochima variant. The very important is also difference between the classical and Entor variants. So Entor variants are generally more resistant and they are found in the carrier state. So polymyxin B sensitivity is present in case of classical, it is resistant in Entor variant. Phage 4 susceptibility, it is resistant in Entor. Beta hemolysis is present in case of Entor variant. Then VP test again positive in LTAR, CAM test positive in LTAR. Then mortality and second attack rate, however, are more common in classical, and carrier stage is present in case of LTAR state. Now the pathogenesis. So pathogenesis, it follows a fecal route. Is acid labile in nature. It requires ion accumulation of 10 to the power 6 bacilli. Alkaline environment, that is PBI or antacids, favor also decrease mucosal integrity. It favors its colonization. Then it releases cholera toxin. Cholera toxin similar to Shea toxin or levotoxin of enterohemorrhagic E. coli. Then that will lead to increased CAMP level. The increased CAMP level, it inhibits the CFTR, that is cytosolic fibrosis transferrin reductase channel, and because of this there is a chloride accumulation that will lead to a lot of watery diarrhea. In clinical features of diarrhea, it leads to rise watery stools, vomiting is plus minus, as well as muscle cramps are present. In the lab diagnosis, the specimen is going to be the either stool or rectal swab in case of carriers. Then transport media is the VR media, that is Venkat-Raman media, the Cary-Blair media. Then microscopically, it is a gram-negative comma-shaped organism having Dartic motility or shooting star motility. Enrichment agar is the alkali peptone water, the sea water. Selective agar is TCBS agar, that is thiocyanate bile salt agar. And serotyping is done, it is 1 and 157. Then management. For management, always remember fluid replacement, that is IV normal saline or ringalactate is given. Drug of choice is doxycycline. Azithromycin or erythromycin can also be given. There is a OCV vaccine, which is a live attenuated vaccine that can be given. It is spring test positivity, and apart from that, other tests that are seen are the given by this pneumonia, that is coins, that is cholera red reaction positivity, catalase positivity, oxidase positivity, indole positivity, nitrate reduction positive, and sucrose fermentation positive. Then the next is amoebiasis and amoebic abscess. So amoebiasis is caused because of Entamoeba histolytica, is the third most common cause of death following malaria and schistosomal infection. It is monogenetic, that is human is the only host. The infective form is going to be the cysts, and the invasive form are going to be the trophozoites. So the infective dose is less than 100. So this is the one with a low infectivity dose. Now these cysts are the one that can survive the chlorination, as well as they can survive in environment after shedding life cycle. So it enters through the fecal route, then mature cysts are formed. In the small intestine, it leads to excision. In the large intestine, again incestation happens, it colonizes the mucosa, and then the cysts and the trophozoites both are found in the feces. Cecum is the most common affected part. Now over here, flask shape ulcer can be seen, and the trophozoites are the ones where that lead to erythrophagocytosis. So virulence factors are the galgalic antigen that helps in trogocytosis, that is attachment to the cells, and cysteine proteases help in invasion of the submucosa. It invades only the submucosa and not the muscularis layer, and because of which flask shaped ulcers are seen. The incubation period is 1 to 4 weeks. Clinical features, it leads to amoebic dysentery, that is also called as traveler's diarrhea. So traveler's diarrhea is seen because of Entamoeba histolytica. It is a colicky abdominal pain is seen, then bloody diarrhea up to 10 times. Then most common, it is asymptomatic in nature only. It can also lead to appendicitis. The complications are intestinal perforation, then toxic megacolon, intersusception, peritonitis, and amoebic granuloma or amoeboma formation. Extraintestinal amoebiasis will lead to amoebic abscess. It is anchovy sauce appearance, and this is because of the hemolysis of the RBCs. And in the there is a presence of trophozoites. Now, presence of trophozoites in a freshly passed stool, it is a gold standard microscopic test for active infection. So there is a difference between amoebic dysentery and bacillary dysentery. Amoebic dysentery, it is having a deep ulcer. Then there is a mononuclear cells that are seen. Bacillary dysentery, neutrophils are seen. Then amoebic dysentery, it is dark red and offensive odor is seen. In bacillary dysentery, it's bright red in color, and it is odorless. And RBCs that are formed in clumps in amoebic dysentery that are discrete in case of bacillary dysentery. Drug of choice is metronidazole and dioxinide furoate, that is parabomycin, can be seen. Then diagnosis is by the stool specimen, that is the wet mount specimen is used. Then in the wet mount specimen, for the cyst we use iodine, and for the trophozoites we use the saline. For management, biopsy and histopathological examination. In culture, there are two types of culture: polyxenic medium and exenic medium. Polyxenic has a low load, so Nelson Balamut medium, and exenic where high load is present, that is diamond medium. And serology is the galgalic antigen. And as I said, drug of choice remains to be the metronidazole, and for the intraluminal amoebicide, dioxinide furoate or parabomycin is used. Next is the leishmania. So leishmania Leishmania causes leishmaniasis epizacala. So the diagnostic form is going to be the amastigot. So there are only two forms, amastigot and the promastigot, where the infective form is going to be the promastigot, and it is given by the sandflies. Now, the amastigot is deposited into the body, and it is diagnosed with the help of LD body, that is Leishmania the bodies within the macrophages. RK39 strain is the one that is used for vaccines, and there is a double rise in the temperature within 24 hours that is seen in leishmaniasis. Then, what are the clinical features? There is a fever, there is a lymphadenopathy, hematospleen, megaly, and hyperpigmentation as seen over here. The treatment, the drugs are called as the antimonial drugs. So this over here is the Sandplasmus phlebotomus. Now the lab diagnosis. The sample. The spleen is going to be the most sensitive sample, and the most preferred, however, is the bone marrow. A blood sample at bronchoalveolar lavage is taken in case of HIV patients. In microscopy, the LD bodies are seen that is amastigot form, which is seen in the reticular endothelial cells of the macrophages. Then this flagellated are the promastigots, which are going to be the active form. Then hypergammaglobulinemia is seen. Apart from that, Napier's aldehyde test and Chopada's antimony test are used. Then on the media that is used is the triple N media, that is apart from that PCR and the skin test, that is Montenegro's test is a type for hypersensitivity reaction that is used. Now other forms of leishmaniasis are PPDL, that is post-Kala-Azar dermal leishmaniasis. It is not associated with incomplete treatment, but it appears again. So it is again caused because of Leishmania adenomyosis infection. There are hyperpigmented patches, and management is miltefosine. Over here you can see this is the cutaneous leishmaniasis. It is caused because of Leishmania tropica. For that, sodium stipogluconate are given. Then over here the nasal septum is involved, that is mucocutaneous leishmaniasis. It is Leishmania brasiliensis is the cause, and the management is sodium stipogluconate. Then drug of choice. So drug of choice for Leishmania duodeni is a LAM, that is liposomal amphotericin B, and for Leishmania recidivans, it is the relapse that happens because of inadequate management or treatment. So next is the traveler's diarrhea. The traveler's diarrhea is the acute diarrhea that occurs in the persons who travel from the developed world to the developing countries, usually due to the ingestion of the contaminated food and water. The most common causative organism is the ETEC, that is enterotoxigenic E. coli. Apart from that, Campylobacter jejuni, Salmonella, Shigella, Giardia, Lamblia, and noroviruses are common risk factors. Risk factors are when traveling to developing countries, consumption of contaminated food and water, poor sanitation, hygiene, and street food. Then clinical features are these symptoms usually occur within 1 to 3 days of the travel. It is associated with watery diarrhea, abdominal cramps, nausea, vomiting, fever, and occasionally blood in the stool. Management is the obviously ORS, oral rehydration solution, and IV fluids in case of severe dehydration. Antibiotics that are given are azithromycin, ciprofloxacin, or rifaximin. Antidiarrheal drugs, that is loperamide, difenoxylate, can be given. Prevention is the drinking of the boiled or bottled water. Then avoid raw food and street food. Maintain hand hygiene. And complications that can lead to dehydration and electrolyte imbalance in the body. Then the next is food poisoning. So food poisoning is an acute gastrointestinal illness that happens because of the consumption of contaminated food. Then etiological agents, the most common cause is going to be the Staph aureus or the Bacillus cereus. Apart from the Clostridium perfringens can also lead to this. Viruses are the rotavirus and the norovirus. Then the sources of infection, they are improperly cooked meat, contaminated milk and dairy products, consumption of Chinese fried rice, stale food, contaminated water, poor handling and poor hygiene. Then clinical features are nausea, vomiting, abdominal cramps, diarrhea, fever, malaise, dehydration within few hours of ingestion. Then management is fluid and electrolyte replacement, as ORS is taken. IV fluids of severe dehydration. Symptomatic treatments is we can give azithromycin or other antibiotics like ciprofloxacin, and also loperamide or difenoxylate can be given in case of diarrhea. Similarly, antiemetics can also be given. Then malaria. So malaria is an acute protozoal infection. This is the most common cause of protozoal death, and this is caused because of Plasmodium species, and it is transmitted with the help of Anopheles mosquito. So etiological agents are the multiple species of Plasmodium, that is Plasmodium vivax, falciparum, malaria, ovale, knowlesi. Mode of transmission is the bite of the female Anopheles mosquito. Blood transfusion, congenital transmission, or needle pricking can also lead to malaria. Then the life cycle inside the humans is a sexual cycle wherein first there is a pre-hepatic or a liver stage where the sporocytes they enter the hepatocytes and multiply to form merocytes. These merocytes then enter into the erythrocytes, and then they form trophocytes and the schizont. The schizont then enters the blood and will lead to periodic fever or the bacteremia. Now very important is that gametes are also formed, or the gametocytes are also formed in the erythrocytic stage. Now these gametocytes, they are taken up by the mosquito in the sexual cycle. These gametocytes, they are then fertilized in the gut to form the sporocytes, and in the ookinete stage, oocyst stage, it then travels to the salivary glands of the mosquito, and further transmission happens. The clinical features are the classical malarial paroxysm that occurs in 3 stages. So there is a cold stage, hot stage, and a sweating stage. So in the cold stage, there is chills and rigor, feeling of intestinal. In the hot stage, there is a high grade fever, 39 to 41 degrees Celsius, headache, vomiting, and sweat stage, there is profuse sweating, and fever subsides. And other symptoms are the headache, myalgia, retroorbital pain, nausea, vomiting, hepatosplenomegaly, and anemia. Complications due to are mostly because of Plasmodium falciparum. It can lead to cerebral malaria, severe anemia, acute kidney injury, hypoglycemia, metabolic acidosis or shock. Investigation, peripheral blood smear. So in the investigation, the peripheral blood smear is done for the malarial parasite, which is the gold standard. It can be either thick or thin. Thick is for sensitivity, while thin is for finding out the species. Quantitative buffer coat (QBC) is used for low parasitical load, and it is done in case of acridine orange. Then rapid diagnostic test, it is done for any Plasmodium species. For Plasmodium falciparum, it is the HRP that is involved, that is listed in the Rich protein 2. Then PCR. Attachment in case of Plasmodium ovale is Duffy antigen and ICAM, and in case of Plasmodium falciparum, it is the Plasmodium falciparum erythrocyte membrane protein EMP1. Natural immunity, no Duffy antigen, sickle cell trait, thalassemia trait, or G6PD deficient trait has natural immunity. World Malaria Day is on 25th of April, and anti-malarial month is in the June. Clinical features, benign features are febrile paroxysm, splenomegaly, and anemia. And malignant, they are going to be cerebral malaria, ulcered malaria, tropical splenomegaly, black water fever, and increased chances or increased risk of Burkitt's lymphoma, nephrotic syndrome, and Dirk's granuloma. Then the prevention can be done by mosquito control, insecticide treated bed nests, then indoor residual spray, and chemoprophylaxis. Cerebral malaria is a severe neurological complication of the malaria. It can lead to unconsciousness or coma in the patient with falciparum malaria. Idiopathogenesis, it is the parasite RBCs. They adhere to the cerebral capillaries. Microvascular obstruction takes place that will lead to cerebral edema, leading to decreased cerebral perfusion. So clinical features: high grade fever, altered sensorium, seizures, coma, necrosis is seen, and investigations for this are peripheral smear, while the other complications are hypoglycemia and metabolic acidosis. The treatment is IV artesunate should be given, and supportive treatment can be diazepam to control the seizures and control the hypoglycemia by giving dextrose. For uncomplicated Plasmodium vivax malaria, the blood stage, the treatment is chloroquine. So chloroquine is given 25 mg per kg, that is day 1 to 3, 10, and 5 mg per kg. So total of 25 mg per kg over 3 days. Radical cure, it is given by Primaquine 0.25 mg per kg for 14 days. It is contraindicated in G6PD deficiency and pregnancy. Uncomplicated Plasmodium falciparum malaria, artemisinin combination therapy is given, or artemether lumefantrine is given in case of Northeast India. 6 doses are given over 3 days, and Primaquine single dose 0.75 mg per kg is given. Then mixed infection, Plasmodium vivax and falciparum. The treatment is artemisinin combination therapy for 3 days and Primaquine for 14 days. Then severe or complicated malaria, usually it is due to Plasmodium falciparum. The drug of choice is IV artesunate. Dose is 2.4 mg per kg. It is given at 0 dose, then 12 hours and 24 hours, and then once daily, and then switch to oral artemisinin combination therapy for 3 days. Then quinine can be used as an alternate drug. Loading dose of 20 mg per kg IV is given, and maintenance dose of 10 mg per kg is given every 8 hours. In malaria and pregnancy, for first trimester we don't give so that here we give quinine and clindamycin for 7 days. For second and third trimester we can go for ACT therapy for 3 days. Primaquine is contraindicated in pregnancy, and in children for 3 days we can give. Apart from that, in complicated malaria, IV artesunate can be used. Then chemoprophylaxis for travelers, mefloquine 250 mg once weekly, or doxycycline 100 mg daily can be used. Then next is diphtheria. So diphtheria is caused because of Corynebacterium. Diphtheria is a gram-positive bacillus. Chinese letter arrangement is seen, and it produces the metachromatic granules that are stained by Alpert stain. The toxin is the diphtheria antitoxin, which is called diphtheria toxin, which is exotoxin. It is bacteriophage mediated. It is a bipartite toxin, having A segment for action and B segment that binds with the elongation factor 2. Mechanism of action, it inhibits elongation factor 2, stopping the protein synthesis, and usually targets the myocardium and the nerves. Then the method of transmission is by the droplet. Then there is a colonization of the upper respiratory tract that will lead to the formation of pseudomembrane. Now, very importantly, pseudomembrane is the one that leads on removal, and the diphtheria exotoxin actually leads to tissue necrosis leading to pseudomembrane. So, pseudomembrane is going to be the pathognomonic feature of it. Clinical features are there are different types of diphtheria. Respiratory diphtheria. Respiratory diphtheria can lead to pharyngeal diphtheria, wherein tonsillar as well as pharyngeal inflammation is seen, pseudomembrane formation, cervical lymphadenopathy, and bull neck appearance. Then laryngeal diphtheria, wherein musky voice is seen and brassy cough is seen. If airway obstruction occurs, dyspnea and cyanosis are seen. Nasal diphtheria is the one that is unilateral serosanguinous nasal discharge is seen. Apart from that, cutaneous diphtheria, wherein punched out ulcers are seen. Apart from that, undermined edges and is covered by a grayish yellow membrane. Faucial diphtheria is another type. Diagnosis is mainly a clinical diagnosis. For confirmation, we can go for demonstration on methylene blue stain, that is the Albert stain. And apart from that, low flux medium, potassium telluride agar-6 test or Alex gel precipitation test can be done. Complications that can lead to laryngeal edema, leading to stridor, cyanosis, extension of the pseudomembrane. Then cardiac complications like myocarditis is a most serious complication. Apart from that, it can lead to palatal palsy, polyneuropathy, and paralysis of visual accommodation as well. Then management is isolation of this patient, hospitalization and monitoring. Then it is to be an emergency condition where diphtheria antitoxic 20,000 to 1,20,000 international units is used, given IV after the test dose. So in mild conditions of nasal diphtheria 20,000 is given, and in case of severe or bull's neck 1,20,000 units are given intravenously. Then antibiotics are benzyl penicillin 25,000 to 50,000 units per kg per day intramuscularly or IV for 2 weeks, and or erythromycin 50 mg per kg per day for 14 days can be given. Intubation or tracheostomy is done for securing the airway. DBT vaccine is given, and for contact prophylaxis, single dose of penicillin is given intramuscularly. The next is the dengue fever. So dengue fever, the clinical features are, it is the abrupt onset of the high grade fever that happens for 2 to 7 days. It is either continuous fever or a saddleback fever. Saddleback fever is the fever wherein there is a high grade continuous fever for 3 to 4 days. After that, for 2 days there is a remission phase, and then there is again appearance of all these symptoms, but it is mild in nature. Then the fever is associated with facial flushing, skin erythema, and associated with body ache, that is breakbone fever, or it is associated myalgia, arthralgia, headache, retrobulbar pain, nausea, vomiting. Then in children it can lead to febrile seizures. In adults, conjunctival suffusion is seen. Then the bleeding manifestations, and the bleeding manifestations that can lead to petechiae and mucosal bleeding. Liver is enlarged and liver dysfunction is seen. Then tourniquet test is seen, or Hess test. It may be positive. Investigations: hemoglobin increases, hematocrit increases. Then leukopenia, thrombocytopenia can be seen on the CBC. And the liver function test is altered. Blood culture is positive for dengue virus. RT-PCR or NASPA, that is nucleic acid sequence-based amplification, is seen. On the ELISA, there is a dengue NS1 antigen positivity seen. IgM positivity is seen, and severe dengue chest X-ray should be done for pleural effusion and ultrasound for ascites. Complications are DHF, dengue hemorrhagic fever, DSS, technical shock syndrome, DIC, disseminated intravascular coagulation, and HLH, that is hemophagocytic lymphohistiocytosis. Apart from that, polycirrhosis, cholecystitis, pancreatitis, rhabdomyolysis, hemolytic uremic syndromes, and hepatitis, myocarditis. So different body parts inflammation is seen. Now talking about the dengue treatment, it is divided into category A, B, C. Category A is the home-based treatment, wherein we ask the patient to increase the fluid intake. ORS, fruit juice, paracetamol is given to control the fever, and bring to the hospital if bleeding manifestations are seen. In group B, this is given in case of hospital management. In hospital management, IV fluids are given 5 to 7 ml per kg for the first hour. For the next 2 hours, 3 to 5 ml per kg are given, and then 2 to 3 ml per kg per hour for the next time, and monitor the vitals of the patient. And in group C, it is done for a case of dengue shock syndrome or dengue hemorrhagic fever. Herein, emergency treatment is given, IV fluids are given, and arrange for blood transfusion, that is platelet transfusion if the platelet count falls to less than 10,000 per mm cube. and appropriate management of complications should be done. So what is dengue shock syndrome? Dengue shock syndrome develops in about 4 to 5 days of the illness and preceded by the warning symptoms. So the warning signs, they are going to be abdominal pain, tenderness, persistent vomiting is present, mucosal bleeds are present, then liver enlargement for more than 2 centimeter, and there is increase in hematocrit and rapid decrease in the platelet count. Mechanism of shock is dengue, it leads to increased vascular permeability leading to hypovolemia and shock. Then the features are these bleeding manifestations are seen, hypotension, thrombocytopenia. Apart from that, that can lead to hypoxia and acidosis. Hypoxia and acidosis leading to multiple organ dysfunction, disseminated intravascular coagulation, and death. Management is group C. Then talking about the next, that is the leprosy. So leprosy is given, there is a classification that is called as the Ridley-Joplin classification, wherein there is a tuberculous leprosy TT, then borderline tuberculous BT, then BB, that is borderline. Then next is the borderline lepromatous PL and lepromatous leprosy, that is LL. Clinical features as hypoanesthetic skin patches, thickened nerves, then the sensory loss is present and the muscle weakness of C. Now talking about the management of leprosy. So management of leprosy, it is divided on paucibacillary and multibacillary leprosy. So what is paucibacillary leprosy? When the thickened nerves are 1, if it is more than 1, multibacillary. When the patches are 1 to 5, paucibacillary, more than 5, multibacillary. And SSS, that is slit skin smear, if it is positive, multibacillary, negative, it is paucibacillary. So what is the treatment for paucibacillary? It is rifampicin and dapsone. Rifampicin 600 mg once supervised and dapsone 100 mg daily should be taken. For multibacillary, it is again the multi-drug regimen. It should be taken for 1 year. In paucibacillary, only 6 months. Here it consists of RDC, that is rifampicin 600 mg once a month supervised. Then dapsone 100 mg should be taken daily, self-administered. And clofazimine. Clofazimine, it has 50 mg, which is to be self-administered daily. And there is 300 mg clofazimine that has to be taken along with rifampicin under the supervision. Then the next is the lepra reactions. So lepra reactions, there are of two types, lepra 1 and lepra 2. So lepra type 1 reaction is a type 4 hypersensitivity reaction. It is seen in borderline leprosy. There are two types, downgrading reaction and upgrading or reversal reaction. Downgrading reaction, it is seen along with the disease, while upgrading reaction, it occurs after the initiation of therapy. Now the clinical features are the existing skin lesions like the macules, papules, plaques. They are going to develop erythema and swelling. New skin lesions may appear and peripheral neuritis or pain appears because of irreversible nerve damage. Management for type 1 lepra reaction is mild, when aspirin is given moderate or severe, then prednisolone 40 to 80 mg daily is given. Type 2 lepra reaction is a type 3 hypersensitivity reaction and is characterized by erythema, nodosum, leprosum. It occurs in lepromatous leprosy LL within 2 hours of institution of chemotherapy. Clinical features, there is crops of painful tender red erythematous papules are seen that reverse spontaneously, but new crop smells appear. In severe reaction, there is a low-grade fever, malaise, lymphadenopathy. Again, mild management is by aspirin and severe prednisolone 1 mg per kg per day. And if it does not subside by this, then clofazimine or thalidomide is added. And complications of the leprosy. So complications of the leprosy are starting with the face. So there is going to be depressed nasal bridge, then facial nerve palsy, then leonine facies are seen, keratitis and blindness. Then in the hands, ulnar nerve is affected, ulnar claw hand, medial nerve is affected, medial claw hand. Both are affected, combined claw hand. Radial nerve palsy is seen. Then in the legs, the lateral popliteal nerve is affected, that leads to foot drop. Medial popliteal nerve is generally spared, and posterior tibial nerve is going to get affected, that will lead to clawing of the toes. And secondary deformities are anesthesia of the part. There is hypoanesthetic fractures are seen that are prone to trauma, infection, infective gangrene, destruction and autoamputation, and trophic ulcers, they are also common. Management of complications or reconstructive surgeries are done. The release of contractions, tendon transfers or arthrodesis can be done. Then lepromatous leprosy. Lepromatous leprosy is the form of leprosy which has the least immune response. It is characterized by extensive diffuse and bilateral symmetrical skin lesions that contain numerous bacilli. Clinical features are nasal symptoms are seen, that is anosmia, nasal stuffiness, crust formation and blood-stained nasal discharge. Skin lesions which are multiple, severe, then extensive, diffuse, bilateral symmetrical macules, papules, plaques, pustules can be seen. They are hypopigmented in nature, macules. The borders of this lesion are ill-defined when the central part is indentated and swollen. Leonine facies and loss of eyebrows and lilasis, motherhosis is seen. Apart from that, blow and stocking anesthesia and loosening of teeth, nasal collapse, shortening of distal phalanges, they are seen in lepromatous leprosy.